Thanks, David. And we continue with session 4. My name is Marc Miravitlles. I don't need to introduce myself. David kindly introduced me in our previous session. So I will proceed with introducing our session 4, our last session for today, which is aimed at discussing about diagnosis and clinical management of Alpha-1. How can we improve the diagnosis? How can we assess the impact of Alpha-1 in the patients, in the carriers and patients having the different mutations? How does it impact the lung? How does it impact the liver? And also the impact of the rare alleles. And then we will have some questions. We'll take your questions. Our first speaker will be Marion Wilkins. I'm sure you all know her. She has been also participating today. Marion was diagnosed with Alpha-1 before finding out that her children were carriers of the disease. Then she approached the Alpha-1 Deutschland, and since 2015, she became president of the Alpha-1 Deutschland. And I want to highlight that also from the beginning, she has been participating in the ARCO. We value very much her input into the development, not only of the registry, but the whole ARCO project. And we are very happy to have her with us. So Marion, the floor is yours.
Thank you very much, Marc, for the kind introduction. And therefore, I would like to start with a reminder. I told in the morning already something about my patient story, and just to remember for all the people coming later, I'm a real patient. I'm an Alpha-1 antitrypsin deficiency patient with a BZZ, so a very low serum level. And I have as well asthma, COPD, emphysema, and bronchiectasis. So it is always easier taking more than one, so you don't concentrate too much on one. Unfortunately, on my diagnosed pathway was that I started smoking early on. I was 15 years old when I started to smoke a pack every day. And then with 20, I got my asthma diagnosis, but I thought it doesn't matter. I'm still healthy and young. So therefore, I finally stopped smoking at the age of 30. Now, I would say much too late, but at that time, I was like many other people as well. I did not see that problem. And by the age of 40, my physician said, your lung values should have been regenerated, but they weren't. And he had a feeling that he should do another test. And this was a test for Alpha-1. It's not good because it was just a lucky shot. So he has just feeling and not the knowledge about Alpha-1. So at the time now, we should have that every physician should think about testing of Alpha-1, whatever lung disease you have once in your lifetime. But at that time, it was just a lucky shot. And also, he said to me, but I even don't know what it means to have the diagnosis of Alpha-1. So we both went back at home and make ourselves getting more information. So he did it on his ways, and I did it on my way. First of all, I asked Dr. Google, and there were lots of horrible things I found, like I will die early on and things like that. But I also got the address of the patient organization in Germany, and they made me feel much more better. They gave me lots of information, and they took off all my fears. And many patients told me over the years their stories of their diagnosed pathway. And yes, it is always a long story from the beginning of the first symptoms to get the real diagnosis. And it still is an average up to 6 to 8 years. So much too long. The first symptoms, and I think this is typical for Alpha-1, is having cough and having shortness of breath when climbing stairs or climbing mountains or whatever, and having less physical endurance. Then shortly after this, I had a feeling of pressure in my chest after lots of activities. Typical symptoms can also be that you have liver volumes which are not okay, and where your physician said, oh, there are some higher liver values than normal. So this is, I guess, the most typical symptoms, which was also my first symptoms. And some of us do have sputum problems as well. The treatment normally, or in my case, is I would remain with my bronchodilator, so to say, with a spray which opens my lung for better breath, which I had already for my asthma. I stay with that. I have to learn more about breathing, facilitating positions so that it's easier for me to breathe. I have to learn how to cough up. And I have to learn a lot about the disease, because the more knowledge you have, it's easier to live with your disease. I will start augmentation therapy soon, and also have regular examinations. What does it mean for me? In my case, personally, I do twice a year a visit to a lung physician. Once a year, I do my liver check. In that case, I'm participating in the register study of the Uni Aachen. I think Pavel will talk about later on. Once per year, I have to go to a center where I can enter my EACO register data. And on daily basis, I have to inhale my medication. And I try to do a lot of exercises, lung sports, respiratory physiotherapy, and things like that. We heard already in the morning, which helps me a lot. And I try to bring it more into my daily life. Alcohol only rarely, and liver-friendly diet. Many of these things are not working every day, but I try to. And what helps me more, I think this is something which belongs also to therapy. My family, understanding in the family about the disease, good cooperations with my physicians or my doctors, my hopes through research, which we heard already from Alice, my positive thinking, and the acceptance of the disease. And last but not least, information like we get today. What I would like to advise before I stop is you should learn to pay attention to your body and recognize new symptoms as well as an upcoming exacerbation. So tell your physician what happens to you. You are knowing your body better than everybody else. But also collecting test results. Ask your physician, can I get the results? Can I get my lung function tests report? Collect them. It is always good if the physician change or you move house or whatever. In my case, I have now the lung function data for, the first one when I started was 20. So I got a lot of data already, and we have the help of these old data set that we know when we should start, for example, the augmentation therapy, which we have luckily in Germany. It's easier if you have all your data available. Know about your values. So what does it mean to have a FEV1 of 60 or whatever? What does it mean to you? and what does it mean in total. So ask your physician that he should explain it to you. And this is also what we have to learn today, or what we had already learned partly today, and take part in the registries and registry studies. This is what I would advise every patient from the beginning on. And in my way of diagnosis and treatment, I hopefully will see now within the next presentations of the physicians that this was not the completely wrong way of treatment and diagnosis, and it was typical, and we will hear now from all the others. Thank you.
Thank you. Thank you very much, Marion. And it is important what you mentioned about the pillars, the family support, the good connection with your doctors, and information, information, information. To have your information, understand your disease, understand your body, the signs that your body is sending you, and share it with your doctors and have a good communication. And our next speaker will be Professor David Parr. David has been sharing the previous session. You know him already. He's consultant respiratory physician at University Hospital Coventry and also professor of respiratory medicine at the University of Warwick in the UK. He has been in research of Alpha-1 for more than 20 years, and we are very happy to have him in the steering committee of EARCO, helping us to move this initiative further. So, David, you will address the issue of the lung disease, diagnosis and management of lung disease.
As I was saying, we've already covered much of the topic in previous presentations and discussions, but I would like to give a slightly different perspective that complements the information that you've been given before, and which provides an insight that's not usually provided in the kind of descriptions of Alpha-1 related lung disease that are widely available online and in general publications with which I suspect the audience is fairly familiar. So the aim of my presentation is to provide you with information on how better to understand how doctors approach the management of lung diseases, to be able to better interpret what you can find online and in publications on Alpha-1 related lung disease, to better understand the information that your own doctors may tell you about your condition, and what kind of issues you should question them about. So I'm delighted to have heard what Marion just said about knowing your own values and what they mean. So I hope that at the end of this presentation, you will have a better understanding of that issue. So the commonest presentations of Alpha-1 related lung disease are listed here. You may be personally familiar with some or all of these symptoms and scenarios. We're probably all familiar with the situation of the first bullet point, which is asthma that doesn't respond as expected. And this probably is one of the contributing factors to the delay in diagnosing Alpha-1. The symptoms that I've listed here in bullet points are present to varying degrees in patients with established Alpha-1 related lung disease and are not particularly helpful in characterizing the nature of that lung disease. So whilst they may be typical, they are not specific. It's fair to say that these symptoms are present in the majority of chronic lung diseases. They're often also seen in patients with heart disease, liver disease, and kidney disease. Unfortunately, we don't have the time for me to explain how this can occur, but it does. The point is they're very non-specific symptoms and are unhelpful in arriving at an accurate diagnosis. Furthermore, if you have any of these symptoms and have an abnormal Alpha-1 genotype, it does not necessarily follow that the abnormal genotype explains your symptoms. You may have something else going on. So the last point is obviously peculiar to Alpha-1, but it never ceases to amaze me the diverse and bizarre reasons for which Alpha-1 antitrypsin deficiency testing is undertaken, often without the patient being aware that testing was occurring, which is not consistent with good practice, because pre-test counselling should always be undertaken. And there was a Q&A comment about that earlier. As you can imagine, this can create a variety of problems, but particularly so when the explanation of the test results is misleading. However, I don't want to spend too much time on that either, because I think we're not going to have time. So what are the commonest questions I get asked by my patients in clinic? Not just by alphas, but by pretty much all of my patients. They don't necessarily use these particular words and phrases, but I've tried to make it easier for the translation. So what's wrong with me? That's usually the easiest question to answer, but rarely, even after multiple tests, the answer can remain unclear. How bad is it? That's when it starts getting technical, and we will be looking at that in a little bit more detail later. What's going to happen in the future? Now we're getting into fortune telling, and I will provide some examples of how difficult that can be. For those music lovers in the audience, you may have heard that the incredible Quincy Jones sadly died yesterday at the age of 91. What you may not have known was that he died 50 years after attending his own memorial service that had been held when he became unwell at the age of 41. And I think that says it all about doctors' ability to predict prognosis, and explains why I nearly always avoid giving any sort of estimate, because it's usually going to be wrong. Next question is, what are you going to do about it? Well, the answer to that is the best that I can within the limitations of what treatments are available for me to prescribe. And sadly, in the UK, that's not very much. And what can I do about it? We're talking predominantly about lifestyle here, and that's notoriously tricky ground. Most people know what a healthy lifestyle is. And I think it's fair to say that nearly all of us do not lead saintly lives, and life often gets in the way of being able to do what we would like to do. So we may get some time later discuss what those most important measures are. So the conventional view of COPD and Alpha-1 is this. This is what was termed the Fletcher and Peto curve, and it's widely used to explain the natural history of COPD, and also one which has been applied to AATD as well. So this is what is likely to happen if you're healthy. You have age-related decline, or if you're smoking and not susceptible to smoke in terms of your susceptibility to getting COPD, that is. This is what happens if you're smoking and you're smoking regularly and susceptible to its effects. And if you stop, the idea is that you continue to decline, but at a similar rate to the non-susceptible or non-smoker. If you continue smoking, you reach a point where you become disabled, and then we've got another line here, which is death. And this was considered to be a reasonable indication of what would happen if you had Alpha-1 antitrypsin deficiency. And it was groundbreaking research at the time, and it still provides some guidance. However, it not only gives the false impression of a smooth course of disease progression, but also that the natural history of COPD and emphysema can be adequately assessed using the FEV1 on its own. And patients viewing these curves may also think to themselves, I wonder where I am on this line, and when am I going to reach those dotted lines of disability and death? The simple answer to this is you cannot extrapolate the average to the individual, and it is therefore an oversimplification of the reality of how chronic lung disease behaves over time. So what do the experts say? That is to say, the experts who wrote this, and this comes largely from the IARCO group. So lung disease in Alpha-1 generally presents at a younger age than usual COPD, and as we know, is often misdiagnosed as asthma. Patients with Alpha-1 are more likely to have basal emphysema than patients with usual COPD, which is true. But this is the really important information. That is that Alpha-1 is highly variable, and there's an enormous amount of heterogeneity in lung disease that's only partly explained by exposure to known risk factors such as cigarette smoke. And then the next bullet point is also, I think, of key importance. The complexity of interpreting the genetic variants, their importance, and the role of patient and family screening, as well as disease management, requires expertise only gained by seeing patients on a regular basis. And that's what I'm going to explore in a little bit more detail. So this is a very a crude but helpful way of explaining how there's a delicate balance between the burden of inflammation in the lung and the protective effects of alpha-1 antitrypsin, which can be disturbed in different circumstances. So inflammation can come from various sources. This is a healthy person who's well, and the seesaw is balanced by the amount of inflammation being counteracted by alpha-1. So inflammation can be precipitated by cigarette smoke, lung inflammation, pollution, occupational risks, and so on. So that's the healthy, well person. A healthy person who gets an acute illness, they'll have a lot more inflammation, but also their alpha-1 levels go up. This keeps the seesaw in balance. In usual COPD, there's more inflammation. There's probably a normal amount of alpha-1, although there may be reduced alpha-1 function as a consequence of the effects of cigarette smoke, and that leads to usual COPD. So if you then take the alpha-1 patient where the alpha-1 is low in amount with reduced function, a normal amount of inflammation unbalances the seesaw, leading to tissue damage. With exacerbating factors like an infection or cigarette smoking, there's a lot more inflammation and the balance is even more disturbed. We don't quite know what the situation is with augmentation therapy. The fact that patients on augmentation therapy still have decline would suggest that the seesaw is not completely leveled, but that's a contentious issue. So if we look at the lung structure and function, this is a fairly typical picture of the airways. These are the major airways, which give some idea of the complexity of the lung, but the location of the problem in alpha-1 is actually beyond these airways, which have been truncated so that the diagram is easier to draw. But they're too small and numerous for them to be included in this picture. And if we look at the parts of the lung that are affected, we're concerned with almost microscopic airways, which are shown here, along with the air sacs or the alveoli at the end of the bronchioles. So the airways consist of trachea, bronchia, and the bronchioles, and the air sacs consist of an alveolar membrane, the alveolar capillaries, and going into that of the pulmonary arterioles and the pulmonary venules, which take the oxygenated lung to the left ventricle, and then that's pumped around the body. So we typically think of gas transfer as reflecting what goes on in the air sacs, and spirometry as what goes on in the airways, and combined together, the effect on airways function and alveolar function, there will be impairment of gas exchange, which we can measure with oximetry and blood gases. But the pictures of these airways are misleading a little, because the lung is not like a topographical map, which is like the London Underground map. In reality, the air sacs and the airways sit side by side, so that damage to the air sacs also impacts on how the airways function. So emphysema will also affect spirometry. The destruction of emphysema takes away some of the supporting structure of the lung and allows the airways to become floppy and collapse, leading to worsening airflow obstruction and spirometry values. So what does emphysema look like, and how does it make you breathless? Lung destruction on emphysema makes the lung look darker on the chest X-ray. You can also see how the diaphragms are pushed down, and that the rib cage is a different shape on the patient with alpha-1. So this is the diaphragm pushed down compared with a healthy lung, and the shape of the chest is bowed outwards. And that's because the lungs are overinflated. And Karen talked about this earlier, and how the way that breathing out is important. Many of you will also be aware that breathing out through pursed lips is helpful. Pursed lips are an expression that we use to describe people who are breathing out as if you're blowing a kiss, and that helps with being able to empty the lungs appropriately. So this again is the same patient. Actually, it's their CT scan, and you can see how the shape of the chest is different. This is in cross section, so this is much more rounded, and there isn't this dip in the sternum at the front of the chest here. This is the backbone, and this is the heart. And you can see how you're not even really seeing the heart in this scan, even though it's done at a similar level, because the diaphragms have been pushed downwards and you've got lung coming beyond the lower level of the heart. And this is bronchiectasis in an extreme form that looks more like the bronchiectasis in cystic fibrosis, but this is in an alpha with PIZZ. And miraculously, there's virtually no emphysema despite the extensive inflammation that must be arising from this airways disease, and we really can't explain this. However, I should say that this is not the usual picture we see. When you look really carefully at the airways on most CT scans, it is often possible to see some of the changes of bronchiectasis in patients with Alpha-1, particularly in those with emphysema, but it is not usually sufficient to be able to say that it represents a clinically significant amount. So there's a spectrum of severity which correlates loosely with the severity of emphysema and airflow obstruction and may influence what we call the clinical phenotype. That means the type of symptoms that you have, such as regular cough with sputum production or more severe infections with exacerbations. So lung function tests remain the basis of how we assess disease severity, and from that, the prognosis in lung disease. It's not just in Alpha-1 related emphysema, but in nearly all lung diseases, interstitial lung diseases, pulmonary vascular diseases, and so on. Yet despite the lack of specific relevance to emphysema, these tests are still seen by some key regulatory authorities as the best way of deciding whether new treatment for Alpha-1 are effective. So I wanted to explain how emphysema affects lung function tests and put it into some form of context. So this is the FEV1 here. This is what this person has actually blown, and this is what they should be blowing in a second. That's a maximum breath hold in, and then you blow out as hard as you can and measure what comes out within the first second. So this figure here is 21% of what you would expect it to be if that person was average for their age and height. This is the vital capacity, which is also reduced. So this is the figure that they blew. This is what you would expect them to blow if they were average for their age and height. So this is 43%. But just to put something in context here, this is the lower end of the normal range, and this is the upper end of the normal range. So that range varies from measure to measure, and therefore the percent predicted value can be slightly misleading. And then if we move on to the small airways, this is the ratio. This is going to tell us whether this person's FEV1 and vital capacity are reduced due to obstruction or whether it's due to restriction from something like an interstitial lung disease. This is the small airways function, and you can see here this is 7% of what it should be, which indicates just how important small airways function is in emphysema, and that's often something which is not focused on in clinical practice or in research. And this is a measure of the lung volume. So this shows how much of a problem overinflation of the lungs can be, and emphasizes why breathing control, as explained earlier by Paul Kobler, can make a significant difference in reducing symptoms of breathlessness. This is the total lung of the volumes volume of the lungs when you're breathing in, and that's twice as big as it should be because they're very overinflated. And this is the volume of the lungs when you're breathing out as far as you can. So that's 2.5 times as much air in the lungs when you breathed out as far as you can that should be there. So this is a huge amount of inflation, which will make that person very breathless. And then we also have the effect on gas transfer. So the gas transfer here is significantly reduced. This is the TLCO and the KCO, which are related. And the effect of all of this is to make that person have a low oxygen level in their blood with a low oxygen saturation. So in this patient, if you look at the FEV1 and the gas transfer, which are the two measures that people tend to focus on the most, they're similarly impaired, suggesting that they both have declined in unison. And that's what our basic understanding of how progressing emphysema affects lung function tests, but that's not always the case. We know that the position of the emphysema within the lungs can alter this pattern, but it's more complex than this because both spirometry and gas transfer measurements are not specific just for emphysema. So I'd like to now give a few examples that illustrate how variable alpha-1 lung disease can be and how important it is for alpha-1 patients to be seen by experts with extensive clinical experience that's not just in alpha-1, and for them to be seen for regular assessments over time. And this is important to understand because I commonly hear that patients experience difficulty obtaining a referral to a specialist alpha-1 clinic. So this is a patient who was referred to their local chest physician with breathlessness at the age of 59. They were a never smoker, except for some passive smoke exposure at home when they were a child. And they were diagnosed at the age of 60 with PIZZ. They were discharged after a short period of follow-up from the clinic with what was considered to be stable lung disease. They were then seen several years later in a specialist alpha-1 clinic in Coventry, where they were found to have worsening respiratory failure with increasing oxygen dependence. They were assessed for transplantation, but this was declined due to their age and coexisting heart disease. They developed severe weight loss and loss of muscle strength with worsening immobility. And then they sadly died 14 years after being first diagnosed at the age of 74, having never smoked. So this is their lung function, and you can see that this is actually the lung function for the previous example that I was giving. So this is typical of the functional effects of severe emphysema on how the lungs function. So this is a case that illustrates just how misleading FEV1 can be. So you cannot always assume that declining FEV1 is due to emphysema progression. So this was someone who'd smoked till the age of 38. They developed symptoms of breathlessness and cough from the age of 20, and they were diagnosed with asthma at age 45. But as is often the case, they found inhalers unhelpful. At that point, they were referred to a teaching hospital department and diagnosed with ZZ alpha-1 deficiency at the age of 50, and then referred to our alpha-1 clinic age 53. So if you look at the lung function test, you can see the FEV1 is reduced, 73% predicted. There's quite a lot of air trapping because the residual volume is increased, so they're not able to empty their lungs properly, and their gas transfer is reduced. So that would fit with emphysema. And this is their CT scan, which does show some emphysema. The lungs look quite dark, but it's not as bad as I would expect it to look for someone with that degree of impairment in terms of the amount of emphysema that I would expect to see. So they were diagnosed with emphysema, but with some asthmatic features. So we did a FeNO measurement. So this is a test that's often used in asthmatic patients and indicates asthmatic inflammation in the airways, and that was increased. We wondered if they'd got an allergic reaction to fungal spores in the atmosphere, that's ABPA, but we excluded that with testing. And then they gradually got worse, but with a marked deterioration and severe wheeze within a matter of hours of moving to a new home. So the blood tests showed that they had a white cell count that was increased with one particular type of white cell, the eosinophil, which suggested an allergic process. They were commenced on inhaled steroids with little benefit, and their FEV1 continued to deteriorate. So you can see how the FEV1, unlike that picture that I showed you at the beginning of the Fletcher and Peto curve, it's wobbling around all over the place, but there's a general decline in FEV1 and FVC. So they were actually diagnosed with bronchiolitis. So their physical signs were more in keeping with bronchiolitis. They had squeaks when they breathed in, which doesn't go with emphysema. And they were started on initially with some steroids, and then we added erythromycin, which is an antibiotic that has been advocated as an anti-inflammatory treatment at low dose. And this just shows you how FEV1 and FVC significantly improved as a consequence of that treatment, which to my mind proves that FEV1 can be misleading in taking that as the sole indicator of disease progression from alpha-1 related emphysema. So it's important to keep an open mind. And then this is another patient who has a complex problem with worsening gas transfer, and that's not always due to emphysema progression. So this is someone who smoked for about 10 years, They were diagnosed with asthma in their 30s, referred to a chest physician, and then 20 years later were diagnosed at the age of 50 with ZZ alpha-1 deficiency. They had some other medical problems from cancer, which required treatment. And then at the age of 60, they were referred to the specialist Alpha-1 clinic. And CT showed that they got the typical basal emphysema of Alpha-1, but they also had the emphysema that more commonly is seen in patients with usual COPD. Their liver FibroScan showed some fibrosis and fatty change, and they were advised to lose weight because their body mass index was increased. They then started to develop an increasing concentration of red blood cells, which is a natural physiological response if you live at altitude where the oxygen levels are low, but it can occur in people with worsening hypoxic lung disease where the oxygen levels are low. And that gradually developed over 3 years. And they started having signs of strain on the right side of their heart on their ECG. So this is quite a difficult slide to explain. This looks as if the FEV1 is going around all over the place. It's actually not changing very much because the axis here is expanded so that there's hardly any change in the FEV1. But you can see that despite stable FEV1, the gas transfer is consistently declining by about 25% over just a few years. So I suspected they had pulmonary hypertension in addition to emphysema, but that was probably from a different cause. So this illustrates how it can be difficult when you're managed in a specialist center to get things organized when you have to travel to that specialist center. But I managed to get the local hospital to do heart investigations to confirm that there was pulmonary hypertension. But before that, they were admitted to hospital with an acute pulmonary embolism, a clot on the lung. When they finally had their heart investigation, the cardiac catheter, that confirmed that they got pulmonary hypertension, which when we undertook further investigations just showed how complicated it was. So part of that was due to recurrent pulmonary embolic disease. It was partly due to sleep apnea, where sleep-disturbed breathing at night was contributing to low oxygen levels during the night. And then their liver scan showed that they had progressed to develop liver cirrhosis with high blood pressure in the liver circulation. And that causes something called portal hypertension, and that can be associated with pulmonary hypertension. So high blood pressure in the portal system, the liver system, can lead to increased pressure in the lung system. And they also were found to have a rheumatic condition, which may have been a contributing factor. So they were put on oxygen and they remained on their anticoagulation treatment. So with regard to the therapy for Alpha-1 lung disease, we've talked a lot about the importance of smoking cessation, rehabilitation. We know all about the bronchodilatory and steroid therapy that's available. Exacerbations are of key importance. They should be treated promptly and aggressively. Augmentation therapy, Christian mentioned this morning, and then lung transplantation, which is viewed, I know, by most alphas as being the last resort. There may be some benefit from lung volume reduction therapies, novel anti-inflammatories, and gene therapies, which we have talked about during the research sessions. So I think the ideal management of Alpha-1 associated lung disease is really down to early recognition and diagnosis so that lifestyle measures can be adopted early. I can't recommend strongly enough referral to an expert center with or without shared care with the local hospital. Accurate diagnosis, including genetics and the clinical phenotype, is critically important. You cannot just assume that if you've got Alpha-1, your symptoms are due to the Alpha-1 related problems. Early therapeutic intervention is clinically appropriate, of course, and there is clearly an important role for detailed monitoring of the lung condition from Alpha-1, but also other potential health problems. I think we've already discussed the importance of registry and research participation, but one of the things I think really has to be pushed on today's session is how important it is to actively participate in your patient support groups and political lobbying. So that brings me to an end, and thank you very much for paying attention.
Thank you. Thank you very much, David, for your presentation. It is remarkable how complicated it may be to really assess the individual prognosis of lung disease in our patients. We know a lot from epidemiological studies, from clinical trials. When it comes to a single patient and an individual decision or a personalized decision, this is really the need for an expert center to really evaluate all the factors that you have mentioned. Now it's time for to change the scene and to move to the liver. We know very well that the liver is the other target organ for our individuals living with Alpha-1 antitrypsin deficiency. And to address the clinical manifestations and management of liver disease, we have Pavel Strand. Pavel works as consultant at the University Hospital Aachen in Germany. He is currently leading the European Initiative for the Study of Liver Diseases associated to Alpha-1 antitrypsin deficiency, and he has been involved in several clinical trials of new therapies for liver disease. Pavel, the floor is yours.
Thanks a lot. I'm the only liver soldier here, so let me convince you first that liver is important, and second that liver is actually much simpler than the lung, given that your head is swelling already anyway. So let's see. Do you see my presentation? Yes. So we discussed, or you have heard probably that lung and liver disease are somewhat different. So Alpha-1 antitrypsin is a protein which is built in the liver to be distributed throughout the whole body. And in the Alpha-1 antitrypsin deficiency, we have a mutation in Alpha-1 antitrypsin, which leads to the fact that the Alpha-1 antitrypsin is retained in the liver. So in the liver, you have just too much of this protein, which makes some kind of liver stress, whereas in the whole bloodstream and in the whole body, you have the lack of Alpha-1 antitrypsin, which is stuck in the liver and cannot get anywhere. So we have two different mechanisms, and because of that, also two different ways how to potentially treat the disease. So the liver disease in Alpha-1 antitrypsin deficiency is, in terms of risks, similar to the lung. So we have the ZZ mutation, which is relatively uncommon, but has very high risk. And we have the MZs that is very common, but carrying only a slightly to moderately increased risk, and SZ, which is somewhere in between, but probably closer to the MZ than to the ZZ. And for the ZZ, we actually have also two diseases in one. The ZZ-related liver disease can manifest in very small children. Some of them, it can become as such severe that they actually would require a liver transplantation. But in most cases, it's not that bad. And if it's not that bad, then they usually live happy for a long time. And if they get a liver disease, it's usually after 40 years of age, so more like in the second half of their life. So if we want to understand how to measure liver disease, we have to understand liver disease in general. And what I will be explaining here is also mostly not specific to Alpha-1 antitrypsin, but is true for pretty much any liver disease you can have. So liver disease develops very slowly, and it's pretty much in all cases a consequence of a long-term problem. So you usually have a slow deterioration of the liver, which can take 10, 20, 50 years or even more. So you don't need to worry that your liver gets bad overnight. If you get it checked and if it looks good, it will stay good for quite a long time. Vice versa, you have to keep in mind that liver disease is very inapparent. So even if you feel well, it's good to get your liver checked, because liver disease does not make any symptoms until a very late stage. So, and if we have a process which develops for such an extremely long time, we have different biomarkers that actually measure different things. And this is what I try to emphasize, because this is one of the most important parts of my talks. So you have 3 different types of biomarkers which measure 3 different things. And these are the liver function tests, which basically every physician can do. Then you have liver fibrosis parameters, which is often done only in specialized clinics. And then you have what we call liver synthesis markers, which basically becomes bad at a very late stage and shows you that basically the surveillance process that we are trying to do was not done, and that we are facing a very advanced liver disease. So these are the classic liver function tests. I tend to call them liver tears. So if a liver is somehow stressed, these liver function tests leak into the bloodstream and become elevated. The half-life of these liver function tests is usually 1 or a few days. So that means that this tells us what our liver experienced in the last week or so. That means that, for example, if you take some drug which is potentially hepatotoxic, that means damaging to the liver, or even if you have all kinds of viral infections, or if you just party hard for a while, these liver enzymes can get elevated very quickly, but can also get back to normal very quickly. And this is the situation in the Alpha-1 patients. We have here all the different genotypes, and you see that on average, a ZZ patient, but even an MZ patient has slightly elevated liver function tests. But in most of these patients, the liver function tests are actually within the normal range. So if you are an AATD patient and have repeatedly elevated liver function tests, it means that you are not an average patient, but you are somehow more sick or seem to be more sick, and you really need your liver to get checked. So these are the short-term liver parameters that are available pretty much everywhere. The more complicated part is to measure the liver fibrosis. So liver fibrosis is a scarring process in the liver. So if the liver is not feeling well for a while, it starts to develop liver scars. And maybe when we go really to the beginning, you see here on the left side this very nice, smooth, healthy liver. And then on the right side, these altered liver architecture, which is due to formation all kinds of scars. And this is what we really want to measure, because this is the chronic stress response that we need to understand. And we have several tools to do that. The gold standard is still the liver biopsy. The problem with liver biopsy is that it's invasive and you don't want to repeat it many times because of all the risks and also because of the pain. So we have a variety of other non-invasive tests. The most easy ones are actually just serum markers that we can measure. The ones we do a lot are ultrasound-based techniques, such as FibroScan or a liver stiffness measurement. And there is also a magnetic resonance that you can use, but this one is not very widely available. So when we look at the liver fibrosis by different methods, you see that a ZZ patient has about 20 times increased risk of developing an advanced liver fibrosis. So it's definitely a very fragile group. The MZ has only 2 times elevated risk, and SZ has about 3 to 4 times elevated risk. So these are much better off. And if we take our large cohorts and study patients with the PIZ mutation, you have about 20-25% of them who have a intermediate liver fibrosis, and about 10-15% who have severe liver fibrosis. So this is the ultrasound-based technique with fibroscan, also known as liver stiffness measurement, LSM. So the big question that, of course, exists is always whether all these things work that we are talking about here. And this you can only know when you have a long-term follow-up of patients. And this is what we did in this study. So we put together about 20 international centers. We did a baseline evaluation of all patients, and we followed them up for average 3 to 4 years to see what happens. And in this cohort, about 5% passed away, and about 5% developed severe liver and lung-related problems. So the liver-related problems are really what we call end-stage liver disease, like when you get fluid in your belly, which we call ascites, or if you get a severe bleeding due to ascites. So these are all very severe signs, which basically lead to an inpatient treatment and carry a very poor prognosis. So if you look at these patients with and without liver endpoints in the follow-up, you see that whatever method of fibrosis evaluation you take, you can relatively nicely discriminate between patients who developed endpoints and who did not develop endpoints. Numerically, the best is the liver stiffness measurement by fibroscan, so that's this ultrasound-based technique. But we also have serum-based parameters that seem to be almost equally as well. And here I'm referring to a serum parameter called APRE and our fibrosis 4 index, which can be measured and calculated with relatively simple blood tests. And if you have such methods, you can try to stratify patients in low risk and high risk, and you can see that both liver stiffness measurement and APRE can do it quite well. The liver stiffness measurement is even a little bit better, because if you have a liver stiffness below 7.1, which was the case in more than 75% of our participants, we did not see a single liver-related endpoint in almost 2,000 follow-up years that we had. APRE has, in the lowest category, has very low, but still an existent risk of liver-related endpoints. So we try to combine these data with lung-based parameters. And as you can imagine, FEV1, which you have heard about quite a bit, is not as good, but a decent prognostic parameter. So if you take a lung and liver-related prognostic parameter, you can do some individual assessments saying whether this patient has higher lung or liver-related risks. And this is particularly interesting when we talk about clinical trials that focus more on one or the other organ. So this type of evaluation would help you to understand whether this patient has a leading lung problem or a leading liver problem. And based on these data and other published data, we came up with a rough guideline how to manage patients with Alpha-1 antitrypsin deficiency. And here we use the liver stiffness measurement, which is here called VCTE. And the patients with low liver stiffness, that means relatively healthy liver, need a follow-up in every 2 to 3 years. And vice versa, the patients with clearly elevated liver stiffness measurement need a more regular follow-up. And if they have a decompensated liver disease, they need to be at a specialist center who can also potentially evaluate them for liver transplant. So this is about the liver in general. The key question is what is affecting the liver, and here we have similar risk factors as we know for the lung. Obviously, for the lung, it's primarily smoking. For the liver, it's obviously to some extent alcohol, although the alcohol data are a little bit complicated, and unlike smoking, where basically every cigarette is bad, in alcohol, a low amount of alcohol is tolerated by many patients, especially when they have a completely healthy liver. What is clearly associated with higher risks are the two things, diabetes and obesity. Here you see a few data that we put together in our cohort of ZZ patients and compared that with the risk seen in MZ patients. And you can see that both diabetes and obesity and even an overweight status is associated with increased liver risks. This is the case for patients with and without Alpha-1 antitrypsin deficiency. But in the ZZ subjects, the difference is most meaningful because they already start with a relatively high risk, and if they get a second hit on it, on top of it, can of course get into or are much more likely to get into a life-threatening problem. So we spoke a lot about ZZs, just a small kind of overview about MZs. So MZ in general, or most MZs stay liver healthy their whole time, but have increased risk for all kinds of liver-related problems, especially when they get a second hit, such as too much alcohol, or for example obesity, and or other diseases like in children cystic fibrosis. So we typically consider an MZ subject not a sick patient, but a patient with a slight predisposition that needs to be aware and needs to take care of their potential associated risk factors. So we spoke about how to recognize liver disease. The even more interesting thing is probably how to treat liver disease. And for now, the liver transplantation is the only established treatment option. But we have good substances in late phase clinical trials. And to understand the substances, you have to keep in mind how liver works. In liver, you have this excess of mutated protein. So to treat that, you try to somehow diminish the production of this mutated protein. And this can be done both on DNA, RNA level, on protein level. The treatment approach, which has the most clinical data, is on the RNA level. So we are trying to block the Alpha-1 antitrypsin production without messing up with the genes, but being one level below the genes, and the RNA level, which has lower risk of kind of causing some mutations with some bad consequences. So the idea how it should work is that you block this excess protein production, and because when you block this, you get less Alpha-1 antitrypsin accumulation in the liver. You may get even further decreased serum AAT levels, which is one of the potential concerns about this drug and needs to be carefully monitored. And as you can see here, this works very well. So these are the data of a phase 2 clinical trial showing that if you use this siRNA, you decrease the amount of Alpha-1 antitrypsin both in the liver and the serum. And you seem to improve the liver-related tests, such as ALT or gamma GT we spoke about already, but also you seem to improve a little bit the markers of fibrosis. But to really see fibrosis, we need longer treatment than 1 year, which was done in this study. The lung function, at least for this 1 year we were looking at, and for the parameters we tested, seems to be stable. And if we look at the adverse effects of the drug, where we compare the patients on placebo and patients who received the siRNA, we don't see an obvious safety signal. That means there are some adverse events, they seem to be similar in the patients who received placebo and who received the siRNA treatment. And the corresponding phase 3 study is now underway and is recruiting all over Europe. So if you have a liver disease, this might be an option for you to get a potentially efficient treatment. So this is just to summarize things. In Alpha-1 antitrypsin deficiency, the genotype determines your basic risk of liver disease, with ZZ being the highest and MZ being much lower. But there is a variety of host-related factors such as diabetes, alcohol, obesity, but even male sex that increases these risks. We have several methods to evaluate the liver fibrosis and to get an idea how good or bad the liver works, and ultrasound is the most widely used one, but we have also serum markers that can be used as a triage tool. And we have an exciting drug in a phase 3 clinical trial that blocks the formation of the toxic protein and might be able to help the livers. And if there are any questions, feel free to reach out to our email hotline to get more information. Thank you for your attention.
Thank you. Thank you very much, Pavel. Thank you for giving us this quick overview about the liver, for telling us how to assess liver disease in our patients, how to prevent also the appearance of liver disease, and in particular, the hope that is coming with these new treatments that may be very effective in treating liver disease in this condition. We will open the questions at the end. We still have one more presentation, and this presentation is from Dr. Tim Greulich. Tim is a senior doctor at the University Hospital Gießen and Marburg. He has also led the Alpha-1 antitrypsin deficiency laboratory in the Philipps University of Marburg. And I can say that Tim was instrumental in starting the ARCO collaboration and the ARCO registry and co-chairing the ARCO initiative for some years. So thank you for your support and your help. And now is your turn to talk about what about rare alleles?
Mark, thank you for giving me the opportunity to talk today. I'm trying to make a complicated topic a little bit simpler. I do hope that I don't make it too simple, but sometimes we need answers that we can digest and then start thinking in a deeper way about that. So what about the rare alleles? And we are talking about the rare disease Alpha-1 antitrypsin deficiency. Now, when you say there's something rare in a rare disease, it's even more rare. That means for some of those mutations, we only have one patient that has been detected. But let's start with kind of the last slide I'm going to show in my talk in a different way. This is what we know, or what we think to know, about the relationship between the genotype, the Alpha-1 antitrypsin level in the blood, in the serum, and the risk for a lung disease. So you have two functioning alleles, two M alleles in your SERPINA1 gene, then you usually end up with a blood level of 90 to 200 mg per deciliter. and your risk of developing a lung disease or an emphysema in non-smoker is not present. It's very low. In smokers, it seems to be something in between 10 to 20%. Now, this number is maybe differing in some of the observations, but that seems a reasonable number there. So if you have one altered gene, and that would be a Z allele for the vast majority of patients that are detected, then your genotype would be MZ. The resulting level would be usually between 50 and 100. And for a non-smoker, as we've heard it, your risk would be normal, or you would not have an elevated risk of developing a lung disease. While in those that have smoked or are still smoking, the risk of developing an emphysema would be mildly elevated. Now, if you have the genotype ZZ, you have two altered alleles, your level would be usually below 50. For a non-smoker, still, you would carry a markedly raised, elevated risk of developing emphysema, and a smoker would have a severely, extremely raised risk of developing an emphysema. Now, I'm not really sure about, Christian has talked about that in the introduction, but let me go back to that thing between genes, mRNA, and protein for a very short period of time here. So in your DNA, you have all the information that is needed to build the proteins. So you could say that the DNA is actually the plan, the building plan, the production plan of how the proteins are built in your body. Those genes need to be transcribed into an intermediate language that would be the mRNA. And then those mRNA pieces would be translated again into another language, the language of proteins. So you would have three different levels: the level of DNA, another language, the language of RNA, and the final product, which would be the protein. The code, the genetic code, is built in a way that three different base pairs code for one amino acid. And you can see that here, that if you start on position 1 with the base G, and then there comes a C, and then there comes any of G, A, C, U, that would code for the amino acid alanine, meaning that a certain triplet of those base pairs in the genes and then in the mRNA would code for a certain amino acid. Now, it's interesting to see, and somewhat important for the talk, that sometimes when one of those base pairs is changed, nothing happens with the translation, and sometimes important things happen. So let's go back to the example I just said. You have the G, the C. In that case, it doesn't matter what the third base would be. The result of the translation would always be alanine. Now let's go back here. If you have the mRNA U and then you have a G, then you end up with methionine, which is a different amino acid. But in the case of you have the U and then an A, then you end up with a different amino acid here. Meaning that it's important on what position the exchange of amino acid would be that gives you a different protein that could be completely different, or it could be just the same amino acid and then the same protein. Now, if something is changed, that's relatively easy. If something is deleted, let's say one base pair is deleted, then your complete reading frame is shifted and everything is messed up. So you get a completely different protein. So the way is from the gene to the RNA to the amino acid, and the amino acids then build the protein. So it's important on what position and what is changed to what. Why is it important to talk about rare alleles in alpha-1 antitrypsin deficiency? The reason is we find more and more rare alleles, the better we look. So if you take a look on that slide, on our first publication on that topic, we found 0.5% with rare alleles. The second publication was 1.44, and the third was 5% of patients of our samples in Germany with rare alleles. So this is the status in 2024. We have 0.5% of the samples with a combination of a Z allele and a rare allele. And we have then some MZs, M rares, 2.5% here. We have also some S rares, and we have some rare rares. So all in all, roughly 3% of our samples consist of a combination of a rare allele with some of the other alleles. Why is that so? Because we've changed the way we look for it. Now, this has been done in earlier times. It was a method that actually looked at two mutations, the S and the Z mutation. And this is still the standard way of doing genotyping in many laboratories throughout Europe, to look for those two common mutations, common alleles of the protein, or of the gene that's then coding for the RNA and the protein. But we've changed to a method where we look at 14 mutations at the same time, still including S and Z, but then looking at other mutations too. Now, this is done together with the company Progenica, and we look at 14 mutations in one take. Actually, it's faster than in the past, and the results are available in a shorter period of time because it's 14 frequent of those rare mutations in one take. How many rare mutations do exist? Now, that's actually hard to describe, but Ilaria, Marian, and Joanna have undertaken a great piece of work, and took a deep look into the literature, and they found that actually over 5,000 different rare alleles have been described during the last 50 years of alpha-1 antitrypsin deficiency research. So many different rare alleles have been described, and some of them have been described only once in only one patient. So because it's so difficult to say something about the rare alleles, we need to group them in a way. And I've tried now, for the sake of this talk, to group those samples, those genotypes, in two ways. So one is take a look at the serum level that results, and the other one is take a look at the clinical consequences this may have. Now, here's what's been known about the serum level of the genotypes we know and we are familiar with. So at the one hand, we have the MM with a level between 100 and 200. On the other end, we have the ZZ, the combination of two Z alleles where we have a level below 50. And then we have the MZ, which is a level between 50 and 100. The S seems to be a little bit better than the Z, which is true for the MS, and which is also true for the SZ as compared to the ZZ. So the order would be M is fine, S is a little bit bad, and Z is worse. So where do the rare alleles now belong? And for the sake of this talk, we've grouped them all together. You have two levels you have to know. The lower level of normal would be 90, or somewhat in the district of 100, and the protective threshold would be something around 50. What does a protective threshold mean? Well, this is a matter of debate, but usually we agree that people who have a higher level above 50 do not have a markedly increased risk of developing a lung disease. So if you now take a look at the as compared to one rare allele, so this would mean one M and one non-M, you would have the same picture as for the Z allele. So the would be in the level between 100 and 200. The non-M would be below 50. And the mixture between one functioning M and one non-M would be in between 50 and 100. The same would be true if you took a look at a more detailed way. If you compare MM, MS, M rare, MZ, and M null, then the whole group of M rare would be comparable to MZ, which would mean that one rare allele, one non-M, would be comparable to a Z allele. If you put that all together, the rare mutations, laboratory data, you could say you need at least one healthy M to stay above the protective threshold of 50 milligram per deciliter. The best would be MM. The worst would be to have two altered alleles, but having one healthy M would carry enough protection to have a level above 50. So this is where we are now. MM results in 90 to 200. Non-M results in below 50. And one M and one non-M would result in a level between 50 and 100. But what does it mean now on a clinical page? Well, let me first do an example of how we find those patients. Now, this is a history of a 50-year-old male with symptoms of dyspnea and exertion, chronic bronchitis, no known allergies. There's not many more things to know, otherwise healthy, but has smoked a little bit. Lung function showed a moderate obstruction and the diffusion capacity was mildly impaired. This is a CT scan with a basally predominant emphysema here. Now, the example was that this gentleman came to my office with a serum level of 35 milligram per deciliter and the genotype MZ. And the methods that there were applied in the external laboratory was that they looked for the S and the Z mutations. Now, as I just told you, this is a discrepant result because usually MZ would have a level between 50 and 100. So if you have a patient or a sample in front of you where the level and the genotyping is not fitting to each other, then you need more laboratory analysis. What do the guidelines say in that instance? You should start with a quantitative analysis of AAT in blood. Then you should do either phenotyping or genotyping for common variants. And usually what's meant by that is SNZ. It depends on the geographical region. But then if it's not really concordant, then you should do the exon sequencing, which is really looking at the whole SERPINA1 gene. So this is what we did. And we found that the gentleman actually had PiZ M-Hurlin. Now, M-Hurlin is not what's supposed to mean by the M. It's really a rare variant that's causing lung disease. So in that instance, you have a patient with two altered alleles. One allele is the Z allele, and the other one is the M-Hurlin allele. It's actually a compound heterozygous state, and this patient has two altered genes. So we do know from the Irish group that those the never smokers, the MZ patients, have a normal lung function. What you can see here is MM and MZ are very comparable in never smokers. That's true for the FEV1 for one parameter of lung function. It's also true for another parameter of lung function. But if you have the MZ and you have smoked, then you have a lower lung function. That's true for one lung function parameter. It's also true for the other lung function parameter. So that tells you what's the green boxes in my diagram. If you have one Z and you have never smoked, you're fine. If you have one Z and you have smoked, then you have an elevated risk. But what about the rare variants? And the best that we know about that comes from a large study that was done in the US. The study was called Spiromics, and they looked at the Alpha-1 genotype, and they compared it to lung function, to CT, to lung function decline during the course of the study. So they really took a really close look at those patients. Now, if you do that, you have here the patients with no Z, no S, and no rare variant on the one hand. And you have a very good lung function of 73% here, compared to the ZZ, and they have a lung function of 38%. So ZZ is the worst, 2Ms is the best. The MZ are somewhat in between. They are at 64%. And if you compare that to the one variant, then you can see something in between the 2Ms and the one altered gene. So meaning that 1M would have enough, and for the vast majority, one rare variant would not be enough to make you really sick. A similar thing is seen when you take a look at the CT scans. Then you have the 2Ms here, they are fine. The ZZs are worse, they have emphysema. The MZs are in between, and the rare variants, they distribute a little bit around that. So for the rare mutations grouped as one, the clinical data say you need at least one healthy M. And that's exactly what we said about the level. So this brings me to my last slide. I think this is simplifying a lot, but we need a simple answer to that really hard question. If you have MM, usually that results in a level between 100 and 200 milligram per deciliter. For non-smokers, no risk for lung emphysema. For smokers, there is a risk. If you have non-M, you usually have a level below 50 milligram per deciliter. You have a markedly raised risk of developing an emphysema, and if you smoked, it's extremely high. Some sources say it's about 90% developing a lung disease here. And for those in between, for the heterozygous ones, if you have 1M and you don't smoke, that's usually fine. But if you do smoke, you have a mildly increased risk of developing a lung disease. And with that, I'd like to thank you for listening and for paying attention.
Thanks a lot. Thanks, Tim, for your nice overview of the risks associated with these rare diseases. Now it's time for having the Q&A session with all the speakers. But while the others join in my screen, I have one for you to start with. One of our attendees asked about the nulls. What about the risk of the nulls if they are heterozygous, or in particular, if they are homozygous for two null alleles?
Yeah, so usually we think, and I agree on that, that the nulls are doing worse, even worse than the Z mutations. For example, in the Netherlands, where augmentation therapy is usually licensed but not reimbursed, there is one There is one thing where this is otherwise, and those are the patients with 2 null alleles, because it is imagined that those patients do worse, and for those patients, actually, there is reimbursement therapy. So in my opinion, the order would be M would be fine, then there would be S, the rare variants group around the Z, and then comes the null mutation.
Thank you. There is one question for David. David, is this still advised that the clinical treatment of chest infections for alphas is via antibiotic treatment, or should this be a clinical decision based on attendance of an expert center?
So that's a very good question, and it's a common theme that we have to deal with in our non-Alpha-1 clinics as well as our Alpha-1 clinics. So the term chest infection is very loosely applied by non-specialists, and I mean non-respiratory physicians, even by some respiratory physicians, and certainly by GPs. So when patients talk about a chest infection, the first thing that I ask about is, well, what are your symptoms? And a lot of patients describe symptoms that I would not consider to be consistent with a bacterial chest infection that would require antibiotics. So that's the first thing to say. The other key question is, how often do chest infections, these episodes, occur? And if they are clearly getting recurrent bacterial chest infections, and I'm looking after them in my Alpha-1 clinic and they are living at a distance, then that is much, much harder to manage, because it's bad enough trying to orchestrate treatment with a local GP. It's even harder when that person lives hours away and you have little direct contact with their GP or with their local hospital specialist. So in an ideal world, I think if there's any question as to whether someone is getting chest infections, I ask them to complete a diary card using the Bronchotest diary card, which was developed by Professor Stockley in Birmingham, and provide sputum samples. That's not practical when someone is living at a distance. And so the reality is it's very difficult to give advice as a specialist center. But essentially, if someone is more short of breath and wheezy, and they're coughing up more phlegm than normal, which is more discolored than normal, then the likelihood is that they should be on antibiotics. And I think that that probably is the clearest guiding principle. If they've got other symptoms and they're not, for example, they're not coughing up discolored phlegm, then some other explanation needs to be sought. And then that's very difficult to do at a distance, although I have diagnosed a pulmonary embolism in the middle of COVID in someone who was living about 5 hours away. So it is possible to identify alternative explanations, but it is not easy. And I think that every situation needs to be considered on its merits rather than just having a blanket approach.
Thank you. We don't have much time, but still, I would like to ask some questions to the panel. Marion, as you tell us about your experience and diagnosis, fortunately, your doctor thought about Alpha-1, but I'm sure that you know many other situations. So do you have any estimate of how long does it take until symptoms appear and the diagnosis is effective? And if there is anything we can do to improve that?
Definitely. Yeah, I think the mentioned number is 6 to 8 years till we have the right diagnosis, but in real life, I think it is even more. So from the really first symptoms, it will take more than this time, because the first cough, the first breathless is what you think is normal. You are getting older, so nobody's going and see the doctor for that. So yes, there is a long way till you get the right diagnosis. And what we can do in total is look at every COPD patient at least. Look at every asthma patient, then we find the younger ones. And especially on that asthma patients who are not going normal, I would say. So if we jump more into the lung diseases, the general big lung diseases, and have a look there, we will find quite more. And also, as Pavel said, in the liver, we also have to take a look. Wherever a liver problem is, we should also have a look.
Thank you, Marion. We have a short time. So I have a couple of questions for Pavel. The first one is, do we need to screen for liver disease all of our emphysema patients?
Yes, but the screening is very simple. So the easiest one is blood based, as we discussed, this apnea or something like that. And as always in medicine, you do things which seem to be clinically relevant. So if you have something who is at a really end stage lung disease and seems to have very normal liver by apnea and all the simple tests, and of course there is no reason to to look for a fibroscan clinic that might be 100 kilometers away. But the problem with liver is really that it doesn't make symptoms. So in lung, if you kind of don't breathe, or you cannot run the stairs as you used to, you start to think about lung. In liver, any symptoms that you have happen at a very late stage. So the answer is absolutely yes.
And another related to this, but very more concrete. When would you consider start studies to rule out hepatocarcinoma? Only after the grade 2 fibrosis by elastography, in all CC, in all SC, by echography? What is the usual procedure?
The problem is answering questions when there are no data. So the bottom line is that the risk of liver cancer increases in a major way when you have a liver fibrosis. So if you have a liver fibrosis or advanced liver fibrosis, you definitely have to screen for HCC, hepatocellular carcinoma. In a liver cirrhosis, you screen twice a year via ultrasound. That would be the standard method. In patients with no advanced fibrosis, the risk is probably relatively low. We recommend ZZ subjects to have a liver ultrasound every year, because mathematically speaking, they have about 40 times increased risk of liver cancer. And we assume that most of them happens in an advanced liver fibrosis, but we don't know for sure.
Thank you. A very short question, and I would like a very short answer as well for Tim. In the figures that you show, there was a threshold of 60 milligrams deciliter, but during your talk, you were talking about 50 milligrams per deciliter. Is there any mismatch
that relates? Yeah, there is a mismatch, and the mismatch comes from the translation from micromolar. 11 micromolar has been the original quote here. And if you just translate that to milligram per deciliter, it's 57. But you take a look at usual normal values and values from cohorts that look at ZZ and SC and MM patients, the border seems to be at around 50 milligram per deciliter. So I guess it's important to know that the level is not the only thing, and you can do that in favor of your patients, and then it would be 57.
Thank you, Tim. It's 3 minutes to 4. We have a few more questions. I'm sure our speakers will be able to answer in the chat or later on by email, but I want to be on time as much as possible, and I want to pass the word to Marion and Karen for the closing comments. Thank you for your attention.
Thank you, Mark. Thanks very much. Firstly, I would like to thank all of our expert clinicians and our speakers today for giving up their time to be with us. I think it's been a really informative session, long sessions. I've learnt new things. It's always a school day. I'd also like to thank IARCO and the ELF who've actually made this event today possible. They've done a lot of the work in the background. I'd like to thank Marion as well for helping me put together this event with their support. But also thank you guys for coming along and joining us for the live event, or even if you're watching the event recording because you couldn't make it today because it might have been a work day for you. I think we've all found it informative. And I know we're going to put a poll up, and we put a poll up at the very beginning asking whether or not how you rated your knowledge. So if you could rate your knowledge again now, based on what you've learned today, that would be really good to know.
Karen, we also should add that all the speakers are here on voluntary basis, which is not always clear on a webinar. So thanks to everybody coming and for taking the time. And also thanks, Karen. It's a pleasure always to realize projects together with you. And we hope to do it again next year. So keep fingers crossed, because the many questions shows how important these events are. Thank you, so everyone who made it possible today, and thank you for your audience, for putting up together and taking the time for the whole day. Thanks.
So, oops, excuse me, my phone's about to start doing things. Where's the poll gone? The results have gone.
Yeah.
Okay, but I think you all said it was
there.
Okay, that's because I'm also trying to bring up something else on my screen. So yeah, 40% of you. I'm not sure what the poll ratings were before, but I'm hoping that that's improved. We'll be able to analyse that after. But one of the things I also wanted to close saying, and that's really a bit of a call to action to the patients and the patient community. So, I hope you've been encouraged today. I was encouraged when I was first diagnosed to become more active and more involved in the patient community. And maybe the same can be said for you, because the Alpha-1 Europe Alliance and your national patient associations are all working really hard to raise awareness and advocate for better access to care and treatments. And also, we need help to support the Alpha-1 patient community. So if you think you could help the Alpha-1 Europe Alliance or your national patient associations, reach out to them, because they're always looking for people to try and do some of the work with them or to help in some way. So it'd be good to see some new faces becoming actively involved with us as we continue to try and make lives of alphas better. So thanks for being here, and thank you once again to all of our expert speakers. Your attendance has been thoroughly appreciated.